smaller infants that they're breastfed or bottle fed, it's easier to tell. But the older they get, the 2-year-olds and things like that, 2 and 3-year-olds that have RSV, you can't really monitor their intake because, well, they have a couple glasses of juice, but you don't know how much is in it. But you can tell how many times they went to the bathroom because these kids typically don't go to the bathroom on their own. So 3 to 4 times in a 24-hour period is kind of the lower end of normal. That's 3 is iffy. I'd be looking for more signs of dehydration, such as tachycardia and dry mucous membranes and sucking on out and things like that. But 4 more is pretty good. So that means they're getting in enough fluid to process through their kidneys and excrete. And that is not an indicator of dehydration, but if they it's like, oh, I've only changed their diaper once in the entire 24 hours or twice. That's a more severe sign of dehydration. Tylenol, ibuprofen as needed for fever and kind of body aches. Ibuprofen, you don't want to give any infant or any child less than 6 months of age. You'll go over that in your pharmacology class. When you look at it, there's no proven benefit to albuterol and steroids because it's not a bronchospasm or bronchoconstrictive type disease pattern. And these 2 medicines help either dilate the bronchus or decrease edema. But anecdotally, they're given all the time. Steroids and albuterol, I give them to a lot of my severe and moderate to severe RSV kids all the time. I see them work, I see them help, but if you look at the research, it doesn't prove it. But we give it all the time. Another one, it would be, I don't know if I put it in your handout or not, normal saline, hypertonic normal saline breathing treatments. The hypertonicity is the increased amount of sodium in there, and that helps mobilize upper airway secretions. So you'll see hypertonic normal saline breathing treatments given. And and again, anecdotally, you can give a normal saline breathing treatment, which is isotonic, so there's the same amount of sodium and chloride within the fluid as there is in your blood. And that anecdotally may help a little bit with these young kids too, especially when you get parents in that are freaking out about their sick kid and they think they're about to die, but they're just sick. If you want to just give a breathing treatment for the parents, I give them a lot of normal saline breathing treatments that kind of help with that stuff too. But again, there's not a lot of research that proves that. Anticipatory guidance, so symptoms usually last 3 to 5 days, give return precautions. What do you think some return precautions would be? So you're in the primary care, pediatrician, or the ER, these kids in no respiratory distress, they got a lot of upper airway congestion, their vital signs all look good, come back RSV positive, and what would you tell your parents when to bring the kid back? What to look for?
Symptoms worsen or last longer than 5 days.
Sure, symptoms worsen, so what are those?
Difficulty breathing.
Cyanosis.
Okay, so you're gonna tell, a lady who works at the airport what's to look for cyanosis?
Blue tinting in the skin.
Okay,
Decrease input and output.
okay. So what does that mean to
Oh.
the lay person?
If they stop wanting to take their bottle or don't have as many wet diapers.
How many wet diapers?
3 or 4.
3 or more.
Good. You gotta be very clear when you're giving anticipatory guidance to these parents because one, they're likely not medically educated at all, 0. And so whenever you say, watch for respiratory distress, before you guys came to this program, those of you that don't have a biology background or whatever, did you know what respiratory distress was? Likely not. Retractions, abdominal breathing, cyanosis of the hands or lips are definitely some key factors. The cyanosis is definitely one, but if they're to the point where they're cyanotic, that's pretty bad. They've already gotten really sick, and those kids typically need to go to the ICU. So yeah, return precautions are key to know when they need to be brought back. Any questions? Macy, you got a question up there? Treatment continued, severe. So these are the really bad kids, the moderate to severe respiratory distress. Again, not a lot of research that says albuterol nebs work, but I guarantee you if you call, if you're in a rural setting, or if you call a pediatric hospitalist and say, I got an RSV kid who's having some respiratory distress, and he asks you what you did, and you're like, well, we're not gonna give him anything because the research says there's nothing. He's gonna, hang up the phone or yell at you for a really long time, or just think you're a general idiot. So you don't want to be an idiot, right? No, none of us want to be, right? We're all in agreement to that, yeah. As far as being PAs, on a tangent, because we have a little bit of time here, you don't want to be the one PA that makes us all look bad, because there are bad doctors out there, but you don't think all doctors are bad whenever you meet them one. It's very not the same with PAs. You run into doctors and physicians, and people run into bad PAs and bad nurse practitioners, and then they generalize that all PAs and nurse practitioners are bad. So don't be the one that makes us all look stupid. Give them some albuterol. 2.5 to 5 milligrams depending on age and weight. We'll kind of go a little more in pharmacology about the actual pharmacodynamics of albuterol. It's a beta-2 agonist, helps dilate your main stem peripheral bronchus. So basically, we all know, because we all had physics in here about the luminal velocity of air going through a steady state system. So when you decrease the cross-sectional diameter of an airway, you're going to, isn't it the 4 times decrease in the amount of air you can get through that area. If you decrease it by half, it's squared on the other end, so it's 4 times less area that's going through. So the dilation of that airway will help accommodate more air going through there, because you can't really mobilize the secretions out of the distal airways. You gotta let the body do that itself, but you can increase the cross-sectional diameter of the airway based on medication to help facilitate airway exchange. And we already talked about nebulized hypertonic saline, useful for upper airway secretion mobilization. Oral steroids, so again, research failed to see the use, but it's common in practice. Give these kids Decadron or Orpred. Decadron's dexamethasone, Orpred's prednisone. We'll talk more about dexamethasone here in CRUIT here real soon, and we'll let the pharmacology people talk more about oral prednisone. But they again decrease inflammation and decrease edema just generally throughout the body, and you're looking to decrease the edema of the distal airways. Supplemental oxygen, intubation if necessary. Right, so this is the intubation. This is your last line of defense. You definitely don't want to do that on every kid, but once you've done all of this, and they've given multiple albuterol nebulization treatments, and there's still, what we call, and I call it guppy breathing. So you just look like a dying fish that's out of water. You're just you look. I mean, it doesn't take a professional to figure that out. You can see those kids and they look like shit. So you want to go ahead and intubate them. Supportive care, IV fluids, nutritional monitoring. This is basically what they're going to do in the hospital anyways. There's no special antibiotic or special antiviral or anything like that. It's basically just supporting these kids so that their body can recover naturally. Any questions over treatment of severe bronchiolitis RSV? Prevention on this, it's standard precautions, and you're going to tell everybody everywhere, how do I keep from doing this? Well, wash your damn hands, and don't blow smoke into your kid's face, and don't let them go on play dates because they're sick. It's, it's very simple stuff, but you feel like you have to tell these people. Anyway, sorry, I'll get off my soapbox. Immunoprophylaxis, so there is a drug that you can give to help prevent RSV, but it's only for selected children. The drug is that word right there. It's a humanized monoclonal antibody. We'll talk more about that in more pharmacology. But it's reserved for infants and children. I'm glad you guys laughed. Prematurity, those ones born under 37 weeks, bronchopulmonary dysplasia, and congenital heart disease. So these are these kids that have congenital abnormalities that would set them up for a poor outcome for RSV. These ones that children in and of themselves don't have a whole lot of respiratory reserve anyways. What I mean by respiratory reserve is I mean that the ability to take an insult to the respiratory system in stride and not decompensate. So there's only so much your body can compensate for to the point where you start to decompensate, and that's when you get sick and die. These kids have less of that, so they will get this immunoprophylaxis, this polysaccharide, trying to help prevent the occurrence of RSV. But just know that it's only for premature infants and these ones that are at high risk for developing complications from this disease. Not every kid gets it. It's not like the flu shot or normal immunoprophylaxis. All right, you guys need a break? We would like you for about an hour and 15 minutes. You guys want to get a break or anything like that?
Yeah.
Yeah, okay. Okay.